I actually had just 5 slides. And then Imran Fazal and Kaisa said, no, please make it to a larger number. And so then one said, okay, give us just one good case and that should be enough. And somebody said, no, just data. And, like that, thank you. So what we did was that we decided to make slides number a little longer. So please don't look at the slides. It just has a message and you must get the gist of what's going on. Because like Nadeem, it's like more of a what perception you get out of a lecture. So the greetings from the Fauji Foundation Hospital. And so we talk about COVID, war, and bird flu, and so much scare. And don't talk about coronary heart disease, but huge majority die with coronary heart disease. Left main is very easy to understand. It's a bifurcation. It has an ostium. It has a body. It has a bifurcation. This is the insurance data of what death was like after an acute episode of coronary artery disease in 1950, where 45% people would die within the first year. And now it's less than 5% who die in the first year. And this change has not been a sudden change. It's been a gradual shift of procedures and practices and data and our own understanding of the disease. And if you look at the outcome of the failure, the emergency cabbage, restenosis, stent thrombosis, and very late thrombosis, you find that this come down so significantly that now is the time to get into this field, and this is where the fun starts. I think we guys worked in the Stone Ages, and now is where the real action is starting. I feel so happy for all of you. And those changes have been in the stents, the imaging, how you understand the disease, and the chemotherapy which goes along, the antiplatelets which go along, the understanding of what size to achieve, and how important is the bed preparation. If you prepare a good bed, it is significant advantage. The role of imaging in all of this. And so for a disease like 5%, left main is a very important aspect to disease, because when you talk about where that does the soul lie, many people feel that it's in the left main stem, because when that is involved, the soul is really in jeopardy. So why is it so important? And because it's in such a proximal part of the vessel where it's so easy to access. Because when you cross from 5 millimeter, 3 millimeter, 4 millimeter, 5 millimeter stents and balloons, suddenly your perception change. I mean, we do not understand that. We talk about there's a stent 5 millimeter for left main stem. Now it's going to come into the LED. And I know for a fact that if you inflate a balloon of 5 millimeter in the LED, that's it. It's going to blow up. So I'm not sure how they're going to put a 5 millimeter balloon in a left main stem, because it will have to stick into the LED. So it's much better to take, let's say, Zeiss, because that number I understand. If you take a 2.25 millimeter Zeiss, you can expand it to 3.5. We've talked about this amongst our group also. And take a 3.5 millimeter Zeiss, you can take it up to 5.5. So you need a stent which can be expandable, which has struts thick enough to stick out and have the scaffold. And so then we need to understand about the calcification, the bed preparation, and so on and so forth. Because there's so much to talk about, I'm just going to try and fly through. And the aim is to make you understand that it is easier than you think, but there's a lot of things which have to go into it. So you've got to understand how to work out a guider, and the dot and the pot and the proximal distal crossings and kissings and the different tools and the backup of Impala, TPM, and how to, surgical backup. No two places have the same protocol. So whatever protocol you follow, you must well rehearse it and organize it in a way that you are very comfortable with it. And it is very important. Like, allow me to give you this. Nasir Hussain was saying that this cricketer, कौन है जो इंग्लैंड का बड़ा अच्छा स्कोर मारता है आजकल? Joe Root क्या करता है कि before the match starts, he goes out in the middle, he stands for 15 minutes and visualizes what's happening. So when he walks in, he understands what's going to happen to him, and it's all familiar to him. And that is what we must also visualize, rehearse, discuss with the team before all these procedures. So we talk about proximal and two-stent technique. We just talked about it. Thank you, Nadeem, for covering that. And the DK Crush 5 shows very clearly that if you have critical lesion in both vessels, two-stent strategy is much more has a great advantage. So the way we decide about any angioplasty, be it three-vessel, left main, or whatever, if it's a complex lesion, it tends to go towards bypass surgery. And if there are more comorbids, the angioplasty starts to step in. And that has a great number of ramifications in that the heart team comes in to help her decide. If the patient has many comorbids, the heart team gets expanded. And these are kind of checklists which they have to go through. And after that, you go to a shared decision making. So if it is such a thorough thing, then why does this happen that we all see patients who come to you totally confused, that somebody said the stent won't work, and somebody said you're going to get your chest open like a watermelon, and it won't be put together. And so patients come to us very confused because no two cardiologists counsel the patient the same way. And then many people do not want surgery. You can have whatever data, but if you use surgery, what's going to happen? And so from the days of when Andrew Grunzig first gave his poster to nowadays where the MACE is less than few percent, this is an example. I could show, I'll try and show this later at the end of this little talk. So we still have great animosity with the surgeons, and they have with us, and they still go around saying that stent is a very temporary thing, it's not going to last. That's their opening statement. So what we need to understand is that we need to make a tailor-made treatment for every patient. It has to be a custom fit. These are different trials and registry data, and there's more detail on this. After looking at this data, the only thing you need to look at this data is the repeat revascularization, which is high in every intervention, which in clinical terms come into 1 in 20. So if you do 20 procedures, one's going to need an ISR treatment. And you talk about a stroke, and you talk about an MI. Let me summarize up front that during PCI, surgery has more MIs, and in post-PCI, patients have more MIs. And stroke tends to be more in surgery. And ISR tends to happen more in PCI. So that's the three basic outcomes which you need to focus on. Rest are discussion. So there's more of the same data. And this data suggests that there's no mortality difference between PCI and CABG for left main stem, this meta-analysis. And look at the revascularization, it's still high. So those three things stay the same in virtually all the trials and data registry that you will come across. And so Nobel and Excel have been talked about so much, but they have totally different outcomes. And one of the difference was that Excel was a very well planned and well thought out and well executed trial, whereas Nobel was a very chaotic trial with first generation stent being used also, and it could not recruit all the people, and so it was very to me it's not a great trial. But when so if you look at the Excel trial did show a significant relationship to the syntax. So higher the syntax, more the ISR. And so based on there's so much publications on data and guidelines, and but the bottom line is what we just talked about. And everybody has given a different recommendation based on how much leverage they want to give it. I'll talk more about this. And after all the discussion, when the induction for Excel was happening, they wanted low and intermediate score for PCI. But when the core lab looked at the CDs, they found that a quarter of them were more than 33 syntax. So Excel actually dealt with very complex cases. And this graph, which was shocking for many, but typically describes a patient with coronary heart disease and intervention, that for the angioplasty does well for 3 months, and then at 5 years it spreads out and surgery has an advantage, but still not statistically significant. And so we have got lots of guidelines, and guidelines talk about the same thing. The guidelines talk about surgery has, the diabetics do much better with surgery, but then diabetics don't do good with anybody. They do worse with surgery, they do worse with angioplasty. Best of people who do not have diabetes. And then at the same time, this main compare came out and showed there's no significant difference in mortality or major adverse events in people with or without diabetes. And repeat procedure was lower in CABG than PCI, same old ISR. And so there's more data that suggests that the mortality is kind of equivalent. And so we understand a lot about these conditions that PCI we talked about as more MIs, AF, and the advantage is that they have less strokes in MI and AF and more rapid recovery, lower MACE. So we understand the advantage of one over the other now quite well. The guidelines across the Atlantic differ a little, and that is because the US guidelines tend to be more stricter. And the European tend to stick on the syntax score, whereas the American tend to stick on the location of the vessel. So choice between PCI CABG becomes tricky because there's such a heterogeneity in not only the patient, but the lesion, the local environment. So the decision becomes tricky, and every place has own practices. So heart team approach seems to have a great advantage, but there's some ground realities. And that is the threshold for performing PCI of left main SEM is becoming very common. The rate of and volume of PCI left main is increasing and surgery is shrinking. That's happening across the world. And there's a marked variability in the prevalence of where it's happening what. And the main concern for many people is whether it's being underused or inappropriately used. And this is happening more so in Asia because of the lateral heterogeneity in our cultural risks and socio-economic factor and the belief in the social welfare system and the nursing care and standards. So how do you talk to your patient? He'll be so confused with all this data. So he'll be really curious to know, okay, Doctor Sahab, main kya karu? So it is, for me, the way I say, it's not just the end point, it's your destiny also. So we understand that so even if you put a lemur, it's going to last for 50 years maybe. But what about the vein grafts to other vessels? So by and large, at 10 years, you're going to be ready for something else. And so for first 3 to 4 years, journey with PCIs is wonderful. And then of course you get, you're going to have an ISR, and that will happen with surgery also. And you must be able to accept 1 in 20 repeat procedures. So last few slides. So the heterogeneity is a real issue in our decision making. And so the real world is that angioplasty is happening and it's become very common. And while we debate on angioplasty and surgery, I think the editorials are clamoring about more data. And I think the time has come that we stop talking about data, we accept that angioplasty is there to stay, and we start defining on the techniques and the stents and the drug therapies and things related to the procedure. And we make decisions with the heart team, which should be intellectually honest, based on not just the international data and guideline, but on the local expertise and data also. So that's very important for us. And I cannot help but show Andrew Grinzik. He's the man who made it all possible for us. And if you care to say this case, we had lots of problem with this. We had this loop and radial, which is quite natural. We straightened out. We took a picture. And you can see the big OM has a problem. The left main has real osteal disease. Although this left main looks, in other views, it'll look tighter. Here it doesn't look tighter. There are a lot of BD appearance right up till the diagonal. And you can see that haziness in the left main, and both the osteums are. So at some point it does look 0-1-1, but it has to be treated like a left main stem. So this is the right coronary artery. And so we had all the scores for us. And so this is what it looks like. The LED, the circ, and the RCA. And so what we did was we started with the RCA and we ballooned, we used micro to assist us in that. And where is the, and some more ballooning. And sorry, I think I missed it. Yeah. Sorry, I missed the RCA. Yeah, so that was the RCA. And there's a lot of diffuse disease, but the flow got going. And then we dealt with the distal LED first. And then the circumflex. And we placed stents in the distal LED and the distal circumflex. And then we dealt with the proximal portion with the DK crush, the usual steps involved there. I'm just going fast tracking it. All the steps, they were put in meticulously in the final pot. And that's the second case going on there. And that's the pot again. So in a pot, if you have a very long balloon, doesn't matter, you can make it stick out, but you must never cross the carina. And so that's the final result. And so thank you very much.